Good morning to everybody. I am Dr. Federica Barzaghi. I'm a pediatrician working at the San Raffaele Hospital in the immunohematology unit in Milan, Italy. We follow ADA2 deficient patient, and I would like to share our experience of a special case today. As we well know, ADA2 deficiency is an autoimmune and immunological disease due to mutations in ADA2 gene. The disease has a wide clinical spectrum, which can range from early onset vasculopathy, which can target several organs such as skin, gut, and more severe manifestations on the central nervous system, as well as recurrent fevers, immune deficiency, and immunological manifestations, which can reach also bone marrow dysfunction. Different therapeutic options have been reported in literature up to now. However, steroids and tumor necrosis factor inhibitors appear to be the most efficacious both in the acute and chronic phases. However, hematopoietic stem cell transplantation, if a suitable donor is available, could be the only therapeutic option for this disease. In our study, I would like to present the case of a little patient, the clinical features, the clinical evolution, and the response to therapy of this patient who was diagnosed with adenosine deaminase 2 deficiency and whose clinical features were resembling autoimmune lymphoproliferative syndrome, and thus confounding the diagnosis at the beginning. For elucidating the genetic diagnosis, we performed whole exome sequencing after transplant, sequencing samples of the buccal swab of the patients as well as peripheral blood of the parents. We used prediction tools in order to understand the possible detrimental effects of the mutations on the protein. Then the high resolution crystal structure of the protein was available, thus we had the possibility to make structural and energetic analysis of the enzyme. And finally, to evaluate, we could evaluate the ADA2 activity on the patient and on the parents. The clinical history of our patient starts in early infancy. She suffered from recurrent infections, mainly respiratory infections such as pneumonia, upper respiratory tract infection, otitis, and bronchitis. And when she was 4 years old, she was diagnosed with severe neutropenia. At the beginning, treated with granulocyte stimulating factor without any benefit. Then she developed hepatosplenomegaly, and bone marrow biopsy showed rare myeloid precursors. The most important causes of severe neutropenia were ruled out. And then, as you can see, she was treated with steroids, prednisone, with a good response. But then the physicians were unable to taper the steroids, and she remained steroid dependent. Although they tried with cyclosporin, mycophenolate, and others. Nearly after, she developed livido reticularis and recurrent fever with abdominal pain, which brought her to several admissions at the hospital. Finally, the general clinical picture looked really like an autoimmune lymphoproliferative syndrome, since she had neutropenia, hepatosplenomegaly, and several biological markers such as double negative T cells, IL-10, IL-18, and vitamin B12 elevated in the plasma. and thus suggesting this diagnosis. For this reason, she was treated with rapamycin and prednisone, but once again, she remained steroid dependent and thus was candidate to hematopoietic stem cell transplantation. The transplant was carried out from a 9 out of 10 matched unrelated donor. The girl was conditioned with fludarabine, tiotepa, and busulfan, together with ATG and rituximab in order to reduce the immunological burden. Then she received a good dose of CD34 positive cells, and she successfully engrafted within the first month after transplant, showing a complete donor chimerism at day plus 33 after transplant. She experienced quite few complications after transplant, namely skin GVHD, gut GVHD, oral mucositis, and CMV reactivation. Finally, she unfortunately developed osteonecrosis of the knee, probably due to the high amount of steroids that she needed, firstly for the treatment of neutropenia and then for the treatment of graft versus host disease. However, currently, the girl is enjoying a normal life. She is alive and well, more than 3 years after hematopoietic stem cell transplantation. After transplant, considering the atypical clinical evolution and an inadequate response to therapy and the absence of causative mutations related to autoimmune lymphoproliferative syndrome, the diagnosis was questioned and we decided to go for whole exome sequencing. It was performed and the patients revealed to be a compound heterozygous for 2 different mutations in the ADA2 gene, affecting the hydrophobic pocket of the enzyme. These mutations were predicted to dramatically reduce the enzymatic activity of the enzyme and thus were highly suggestive for causative mutations. One was inherited from the mother and the other from the father. Indeed, we had the chance to check the enzymatic activity of the patient after transplant, and as you can see, it falls exactly in the range of the normal donors, suggesting that really the transplant was curative for the patient, and the mother and the father showed a reduced activity which is comparable with the healthy heterozygous carriers of the disease. Thus, to conclude, we can say that the early diagnosis of adenosine deaminase 2 deficiency is crucial in patients with hematological manifestation, because these patients can promptly undergo hematopoietic stem cell transplantation with complete recovery from the clinical manifestation of the disease, and we can avoid further evolution of the disease. Moreover, the genetic diagnosis, if possible, should be reached before transplant, because knowing that the patient is affected by adenosine deaminase 2 deficiency can influence the transplant procedure and the decision making for the transplant and the conditioning. Finally, however, if the hematopoietic stem cell transplantation is mandatory and cannot be delayed due to clinical reasons, the unrelated donors should be preferred if ADA2 is suspected, in order to avoid that a mixed chimerism with a relative who is carrying one single mutation impairs the result of the transplant. Thank you for your attention.